Welcome to our webinar this evening called Navigating Dialysis with PKD, Options, Tips and Support. I would like to introduce Roxanne Perry, Tanya Smolonogov, Lesley Tozer and Karen Walsh. So we'll start with Roxanne. Could you introduce yourself and tell us about yourself?
Hi everyone. So I'm Roxanne. I'm from Kidney Health Australia. My background, I've been at Kidney Health Australia now for about 8 or 9 months. So I'm pretty junior in the organisation because there's lots of people that have been there longer than me. We're a small organisation that nationally supports people living with kidney disease and kidney failure, right from when you first get diagnosed all the way through to needing dialysis and transplantation. So my role at Kidney Health Australia is I'm the Kidney Health Manager. So I'm the clinical eyes and ears of the team. So my background is I'm a renal nurse. I did my renal training in 1994. So I've been around in the renal world for quite a while. I've seen a lot of change, and the exciting thing is that all your options today are much better than they were in 1994. I've also worked in the commercial field in industry, and I worked for Gambro and Baxter, selling dialysis machines and installing them and teaching nurses how to use them. So I've also had that bit of experience as well. So that's me.
Fantastic. Thank you, Roxanne. Now we'll go to our other renal nurse. Tanya, would you like to introduce yourself?
Hi,
No,
I'm
you're good.
Tanya. Oh, good. My name's Tanya Smolonogov. I look after patients who need to understand about what dialysis is, and I'm based in Western Sydney and Nepean Blue Mountains, which covers over 9,000 square kilometres. It's really important for patients to make an informed decision, and my role is to educate patients about all the treatment options that are available, and also talking about the pros and cons of each treatment, and it's looking about the reality of treatment for our patients as well. Making an informed decision is really, really important, and we have a very robust education process in Western Sydney where we have group education days for our patients and also follow up with one-to-one education, bedside education, home visits to make sure patients are getting the information they need. A lot of our patients do go home on a home therapy, which is really, really quite a testament to the staff that we have here, but also not everyone can do a treatment at home. So some of our patients go into the hospital system and have dialysis, and also some of our patients choose not to have dialysis and we can support them as well. So I've got lots of qualifications. I like to study, so that's just on me. But for me, it's the rewarding part is patients are walking away with the knowledge that they can actually make a decision. They're empowered to actually question their doctors, actually be not shy about asking questions of their doctors and encouraging them to say, hang on a minute, this is my time. I'd like you to answer these questions. Otherwise, it's not a shared decision. It's just, I'm just flailing. So for me, it's making sure our patients and our clients are really empowered to make decisions and no questions off the table. So if you want to ask it, I'll answer it. Nothing seriously. Otherwise, how do you make a decision what's going to be right for you?
Brilliant. We are so glad that you have joined us this evening. That's wonderful. Now I'd like to hand over to Karen, one of our PKD community members, who has been through a journey of dialysis. Karen, could you introduce yourself?
Sure. Hi, I'm Karen Walsh. I have polycystic kidney disease, which we didn't know about in my family at all until I was diagnosed at the age of 35. After several UTIs and asking for a scan. And when the doctor told me it was genetic, I encouraged my mother to get checked. And she said, no, it's not in our family. Even though my grandfather died at 57 of a heart attack, which was probably caused by his failing kidneys, because when we looked at his death certificate, he had kidney disease. 20 years later, my mum did decide to get herself tested, and she also had polycystic kidneys and quite quickly went on to dialysis. Hated it, didn't cope well with it, but she came over to Australia to visit me from the UK and did well with her PD, but then had complications and died at the age of 71. I started on peritoneal dialysis and did that for about 3 months until I got peritonitis and had to move to a Hickman line. PD didn't really work for me that well anyway, and so I moved on to hemodialysis. I've had a couple of transplant opportunities that didn't work out because of COVID and because I had a respiratory issue on the second time. But I got my transplant 3 months ago. I've just celebrated my 3-month post-transplant and I feel fantastic. It's the best gift ever. And it's been a long and awful journey. I've had a lot of problems through the 4 years, but I'm through it and I feel amazing now. Yeah, that's me.
That's wonderful. Thank you as well that you could be here tonight, and we'll hear more about your journey later. And congratulations as well on your transplant. It's really the best outcome.
It is.
And now, last but not least, Lesley.
Unmute. Hi, everyone. So I'm Lesley. Tell by the accent, I'm originally from Scotland, half Scottish, half Aussie. Moved here when I was 22. I'm now 44. And at the age of, I'd say 27, I started developing symptoms of kidney disease, which I was unaware was kidney disease. I visited 5 different GPs over about 2 years, and unfortunately, because I didn't have any kidney disease in my family, or you know, I guess any type of diabetes or other health issues, they didn't seem any urgency to do creatinine or kidney function tests. So I'm the typical poster child for essentially. Fast forward from 27 to 29, I went from just having fatigue and swollen ankles to starting to vomit and throw up, and just actually thought I was pregnant. Long story short, I wasn't, and I had an amazing lucky number 6 GP that decided to do a full blood count. Within 4 hours, the results came back, told me that there was an ambulance on the way coming from the Alfred. My creatinine was over 1200 and I was not in a good way. Went into hospital. That was 2012. Started emergency dialysis. Had aggressive chemotherapy for about a year. Intravenous cyclophosphamide through a Hickman line. Initially, they thought it was leukemia because I do have that in my family. However, after a few weeks in the Alfred, who were amazing, we discovered it was a rare. But then I found it's not so rare because I have spoke to several people. It's called good pasture syndrome, which is a type of nephritis. And so I had the treatment, the cyclophosphamide and everything to put the condition of good pastures into remission. However, unfortunately, my kidney function did not return as much as they had hoped. It returned to about 20%, which would have been okay, probably. I was told for maybe 5-10 years, maybe even longer, depending on how I control my blood pressure. However, I was also told that I would not be able to conceive a child or get pregnant. I had actually dialysis brain today is actually a thing. I've got a lot of fluid on me because of the weather, so I do apologize. I missed an important part there. So this had happened about 2 months after I'd gotten married and come back from my honeymoon. And a year after the treatment, after the chemotherapy, the good pastures was put into remission, which was amazing. However, I was left with about 18% function. And then a year after that, 12 months after that, I was on the pill and I got pregnant. Amazing. However, I was told that because of the pregnancy, as amazing and as unusual as it was, because they didn't think I'd get pregnant, there's a very big chance that with having such a reduced kidney function, that either I could lose my life or, my son, or you lose my function and most definitely start dialysis. And I was recommended against it. However, personal reasons, I went ahead. I saw it as a miracle, and he is a miracle. He's actually outside right now, distracting me, playing football. He's a strong 13-year-old boy, despite the fact that he was born by emergency Caesar at 29 weeks and 1 kilo. Wow. He was put into NICU for 7 weeks. I went into ICU. I started my dialysis journey on PD. Like Karen, I was on PD for 3 years at home. And then I got the dreaded peritonitis. And then I went through a very interesting journey with fistulas. And by interesting, it works incredibly for lots of people. For myself, probably due to my stature, I'm just over 5 foot tall and very small. I ended up I had over 30 surgeries on my arm, including a bypass underneath my armpit as well, with just consistently failed fistulas. Due to the failed fistulas, I also had a heart attack about 6 years ago, due to high potassium and uncontrolled high blood pressure. And so I now have my little lining that's permanent and doesn't look that pretty, but I don't care because it means it works and there's no more needling. I've been on dialysis now 13 years. I've been on the transplant list 12 years, and hopefully I will get the call someday. I also work for Kidney Health Australia in between my dialysis days, which are Monday, Wednesday, Friday, which I absolutely love doing. I work as a community engagement coordinator within their Kidney Buddy program, and before that I was working with our wonderful bequest supporters and community. And I guess I figured, hey, I've got I've kind of been through the whole menu of anything that can go wrong on dialysis has pretty much happened, including 5 grand mal seizures, heart attacks, you name it. So I figured I may as well put it to good use and see if there's people that I can help in some way and guide. So that's it. Sorry, that went a little bit over. I'm Scottish, it's a thing. I really tried to keep it condensed, but
no, I don't think there was any part of that you should have cut off. You've yes, you really have tackled pretty much everything dialysis can throw at you, and we're grateful that, as horrible as those experiences have been, that you can share that with people tonight. And I also would like to say a special thanks to Kidney Health Australia, Roxanne and Lesley. This webinar would not be possible without you guys and without the support of Kidney Health Australia. So we're really grateful to be doing this with you. So without further ado, Roxanne, I am going to hand over to you and we can begin the presentation.
No problems. I'll just share my screen. Hopefully everyone can see that.
Yep.
Perfect. Okay, so I'm going to talk tonight a little bit about and one of the resources. So at Kidney Health Australia, we have lots of resources on our website, and some of you might come across things in your renal units around the place that are booklets and information for people that are dealing with kidney disease. And carers as well. So there's all sorts of information on our website. This is a new shared decision-making resource. Now, there has been a resource that's like this before, but last year we had a little bit of grant money from Baxter, and they helped us, and Tanya actually was quite integral in putting this together, because she does believe in the shared decision-making, which she's always talked about, she already talked about. So the resource that I'm going to talk about tonight is called My Kidneys, My Choice, and it is a shared decision-making resource. So it's a booklet that you can download from our website, and it's only just been released, so there will be hard copies of it coming to a dialysis unit near you soon, but until then you can download it and print it off yourself at home if you need to, and within the next few months you'll see it out and about in renal units. So this is to help you think about what sort of dialysis you might like to choose when you are coming to the kidney failure end of your kidney disease. So what it talks about, it starts with helpful information about different options when your kidneys stop working. So the first thing I'd like to tell you all is that the best choice of treatment is the one you make yourself with a good understanding of the treatment. You need to consider how it affects you and your lifestyle, and take into account your healthcare team's advice. So there's a few things you need to think about, but you really need to make the choice that is right for you, your family, and your lifestyle. So, and listen to your healthcare team, because they'll know how to guide you. So things to think about. So the guide goes through different things to think about. So you think about the first part of the guide is the kidneys. So not all treatment options are suitable for everyone. So based on your health and overall situation, your kidney failure options will be discussed with you by your healthcare team. So it talks a little bit about that. And then My Life. So this is a part of the booklet, and it's sort of like a booklet that you write in, and you can sort of like a workbook. So it helps you think about specific areas of your life and how the different treatment options may change or affect them. So you can weigh up the factors to help you make a really informed decision on what treatment that you would prefer. And then the next part goes into the options, which we'll talk a little bit more about shortly. But there are three main ways of treating kidney failure. So there's dialysis, kidney transplant, and comprehensive conservative care. So that's so your thoughts on which one is best for you may change over time. So it's good to be aware of all the options so that you have a really good understanding of, you might choose one and then later on say, actually, I might like to change my mind and do something else. So then we encourage you in the booklet to think about your choice. So are you ready to make a choice? Do you understand all the options available? Have you spoken to your healthcare team for their input? Have you talked to your family and friends for their input? And do I still have any questions to help me make that choice? And that's when you need to reach out and ask potentially your healthcare professionals to help you with those questions. And when you do have the questions, you need to write them down, because you might think about it in the middle of the night and go, oh, I really want to ask my doctor that question. So have a little notebook book and write it down so that when you do go to your appointment, you've got those questions written down, because lots of things happen at doctor's appointments. And if a lot of time you'll walk out, sit down in the car to drive off and realize that you forgot to ask that really, really important question that was burning for you. So it sort of looks a little bit like this. So this, I talked about the workbook. So, we'll talk about, things like My Life. So for an example of this page is, what's important to me now? How do I feel about the time I can spend with people at home, my relationships, the things that I do with my family and friends and my community, my work or my study, my leisure activities, my hobbies, do I do some sort of sport? Will I be able to continue that? So they're really important things to ask your healthcare providers. What about holidays? So all of those things. So the booklet goes through all of those sections I just talked about and has this sort of workbook appearance so that you can write down all those questions and really think about all the things that you need to think about to make that decision. So the main types of kidney failure treatment. So the first one's dialysis. So with dialysis, special equipment does the job of cleaning your blood. So there are several types of dialysis, and the following sections of the book will help you think about which would suit you best. And dialysis is the most common type of treatment for kidney failure. So it's the most commonly used treatment that there is. There's transplant. So when you have a kidney transplant, a kidney from another person is placed into your body surgically. And the kidneys come from either living donors, so people that have donated a kidney to you, like a family member or a friend or someone that matches your blood type, or they can be from deceased donors where people give the gift of their organs to other people, which is the most common way in Australia that kidney transplants occur. But if you do have a living donor, that may mean you can have a transplant before you start dialysis. So that happens a lot in children that, that they know that they've got a kidney disease and their parents can give them a transplant, and potentially they don't have to start dialysis. They wait until the point where they're sort of nearing dialysis, and then they have a preemptive transplantation. So it can happen, but it doesn't happen as often as we would like, I suppose, because that would be the best, easiest thing, wouldn't it? But it's hard to find donors, and the deceased donors, you don't know when they're going to come. So, and then comprehensive conservative care. So, you may decide not to have dialysis or a kidney transplant and choose comprehensive care instead. So what that is it focuses on treating the symptoms of kidney failure through medication, diet, and other supportive ways to allow you to live as long as possible, as well as possible. But it cannot stop the decline of your kidney function. So for older people, sometimes they choose this as an option because they want to just maintain their quality of life and not have to do the dialysis, which is quite invasive. So this is the types of dialysis. So we've got peritoneal dialysis, So this picture shows how it works. So the clean solution, the dialysis solution, goes into your tummy via a tube. So that tube stays in your tummy all the time. So it gets implanted in a surgical procedure and it stays in your tummy and the fluid goes in and out. So you have a catheter on your tummy. Once the fluid's in, it takes out all the waste products from your blood and any extra water. And then you drain out the old solution into via the tube and it flows into a bag. And then you continue to put clean solution in and dirty solution out. And you can do that either every 4 hours in what we call ambulatory peritoneal dialysis, continuous ambulatory. So you put some clean fluid in, walk around for 4 hours with it in, then drain the dirty solution out and put some clean one in about every 4 hours during the day. Or you can have peritoneal dialysis overnight, which is probably one of the more common ways to do it, where a machine changes the solution for you every hour or so, and you hook up when you go to bed, and then you disconnect in the morning and go about your day. And you do that every night for most people. Some people can do it for 5 or 6 nights a week, depending, but most people do it 7 nights a week. Then you've got hemodialysis. So in hemodialysis, you have to have some sort of access, and Lesley talked about a fistula, which is a vein and an artery joined in your arm that you put some needles into, and you'd get the blood out. So basically with hemodialysis, you have to get the blood out of your body, put it through a filter that's sort of like an artificial kidney, and it cleans your blood. And then the clean blood goes back into your body. So it's like a big circle, it goes round and round. And you do that 3 or 4 times a week for anywhere between 3 and 5 hours is standard. You can do that at home or you can do it in a dialysis unit. So there's 2 options. Peritoneal dialysis is always done at home or, out and about if you're doing it ambulatory. So some people will go to work and do an exchange at work, or they'll do the overnight. So hemodialysis, more commonly in Australia, we see that it's done in dialysis units, either in a hospital or in what we call a satellite unit, which is like a community health centre outside of a hospital where people go in and have dialysis and then go home again. And then a kidney transplant shows the body with a kidney. Now, everyone thinks that the kidney goes in their back, but in fact, it goes in the front. So it goes on to it connects to the bladder and to one of the main arteries that come down from your heart. And most of the time you leave the old kidneys that aren't working anymore, you leave them in because sometimes they can be doing something and you don't want to have surgery unnecessarily. But sometimes with polycystic kidney disease, if they're very large and cystic, they might remove them prior to transplant. So that's commonly what happens with PKD. So the take-home messages really is when the time comes and you need to think about the different kidney failure treatments, think about how they would impact your life, and it'll be helpful to discuss all your options with your healthcare team. They will listen to your wishes and situations, so you can make an informed decision together, which we really like to encourage shared decision making. So something that you both can come to an agreement about, because if you're really involved in your care and the choices you make, then it's going to find the journey, which sometimes is bumpy, which is what Karen and Lesley have told you. It's not the easiest journey to be on, but if you've made the choice and you're really informed, you're going to be well armed to work through the challenges that come with being on dialysis and transplantation. And the overall aim really of using the resource and talking to your healthcare professionals is to achieve the best possible outcome for you and what you're happy doing. So some people like doing dialysis at home. Other people feel like they don't want to bring their treatment home and they'd rather go to a dialysis unit. And that's all really individual for everybody. So I'm going to plug some kidney health stuff here, just the last little bit. So we have a lot of resources on our website. You can scan that code if you're quick enough with your phone and take it to the resources page. But if you search kidneyhealthaustralia.org.au, you'll come into our website and there's a lot of information. So we have booklets that are really quite useful that you can order on our online shop. They talk about an introduction to all the options, hemodialysis, transplant, all the different options, and you can have them, and they've got a lot more information in them, a little bit more succinct. We've got some resources for First Nations people, and we've got some recipe books that might help you if you have to choose kidney-friendly recipes. So they're all on our website, and you can download all of our resources. So you don't have to buy them. You can download them and read them on your computer or your phone, or you can print them off. We also have community programs. So we have support. We have tailored information and support for people with kidney disease. So we have our kidney helpline that you can call Monday to Friday anytime, and you'll have beautiful people like Amanda, whose photo is on the screen, who will answer your questions and help you navigate your way through. So feel free to call us anytime. We also have a kidney buddy program. We do kids and youth activities in a youth program. And of course, we have renal nurses that are champions for, I think, everything kidney. So they're always a good resource as well. And I'll just highlight a little bit about the Kidney Buddy program, because when you do come onto dialysis, sometimes it's nice to have someone to talk to. So we do have a Kidney Buddy program, which is a peer support program, which connects people living with kidney disease, donors and recipients, carers, parents, family members, with a hand-picked kidney buddy who has lived experience and can provide some support. And they'll be someone to talk to on the end of the phone. Some of our buddies will meet up with you if they're in your local area, have a coffee. And some of them even have gone to people's first dialysis with them when they make a really good connection with each other. So if you're interested in talking to a kidney buddy, please reach out to us. Or if you want to be a kidney buddy, then absolutely, Lesley will point you in the right direction there as well. She helps with our kidney buddy onboarding program. So that's it from me. Thank you for listening to me. And if there's any questions, I'll take them from Jess.
Amazing. Thank you so much. You really have equipped us with some great practical tools and resources. So thank you so much for that presentation. And yes, there are a few questions relating also to what you have just spoken about. And I'm going to start with the questions that were sent through previously. But everyone still feel free to pop stuff in the Q&A because I will also be monitoring that. So first of all, starting with, I guess as you mentioned, peritoneal dialysis you can do from home. So one of the questions that came through was, do I need to buy special equipment to make PD at home easier or safer or more efficient?
I could probably answer that because I used to work for Baxter.
Yeah.
No, you don't. Not necessarily. Some hospitals will charge you for some ancillary packaging and dressings and things like that, but all of the dialysis supplies are covered by Medicare, and most hospitals cover the cost of those. So the actual dialysis equipment and fluids and things don't cost a lot for PD, but I know that some hospitals will give you all the dressings and stuff free of charge, but other hospitals will be a little bit of a surcharge for some of those items. Is that what in your experience, Tanya?
Yeah, it depends. Each unit's a little bit different. Like some of our patients have scales. They need to do their blood pressure, some of the basic foundations of just managing the treatment at home, and maybe some hand soap. We use paper towels for our patients as opposed to using bath towels. So every unit is very different, but there's really not a lot of cost involved. It's just about managing, and we supply all the supplies so that you can do your treatment at home. So there's only a few things that you need to get.
Okay, fantastic. Well, then that also answers a few other questions that came through about the cost of dialysis. So I guess off the back of that, would there be any difference in cost between hemodialysis and peritoneal dialysis?
Hemodialysis, there is a difference. If you're doing a treatment at home, if you're doing a hemodialysis at home, all the machinery in our particular unit, the machine requires a separate electrical power point, and it also needs some plumbing. We provide that, and we absorb the cost of that. There is the machines or the equipment, all of that is supplied apart from the blood pressure machine, all those small little things. There is a usage of power and water, and a lot of our patients who are on home hemodialysis, they actually get rebates from the government for power and water, but every state rebate amount is very, very different. So when someone has their machine actually installed into their house, the technicians fill out the paperwork for our unit, and then it goes off to your electricity and water provider. And also when someone does that treatment at home, if there's any issues, like if there's mains water or there's waterworks or power works, you're notified so that you can reschedule your treatment. So there are some costs, but they're not huge costs because you do get a rebate.
Okay, fantastic.
And sometimes some of the units around Australia may charge you. You might have to pay for the plumbing if you don't have the right plumbing. You know, you might need a new tap put in, or you might need a new drain put in, or something like that. But they a lot of hospitals will help you with that cost, like Tanya said her unit does. You know, I've helped them install home hemodialysis in the wilds of Tasmania. So nowhere's impossible to have dialysis at home. They have it in the Northern Territory, on communities, but there is a little bit of equipment, and it does take a little while to get set up and make sure, because you need a lot of water for dialysis. So you can't use bore water, so you have to have sort of mains water. So if you're in the country, then that, you know, your water supply is something you have to take into consideration. But so there are little bits and pieces you need to think about, but most of the time we can get the units can get past that. And yeah, but if you're in a rental property, that can sometimes be a little bit of a barrier, because you have to get permission to install you know, anything that might need to be installed. So that would be something to think about as well. But all your home dialysis units will be able to help you with those things, and no problem's really unsolvable that I've found if someone really wants to do it. I know there's a few people traveling around Australia in caravans doing home dialysis, and I even know a guy in the Territory that would dialyse in a tent on hemodialysis. So
that's fantastic.
If you look up dialysis staying alive, you'll meet him, and he's got a little video on YouTube about how he stays alive on dialysis and all the things he does. He's dancing around. So
it's pretty amazing.
He's a pretty amazing guy.
Don't let dialysis stop you.
No.
Lesley and Karen, I'd actually like to ask you, did you want to go on a holiday, or did you have to travel somewhere, or did you ever take dialysis on the road with you? How have you found that?
Sure.
Lesley?
Would you like me to go first? Yeah, absolutely. So whilst I was on peritoneal dialysis, I travelled around Australia with my family, at various locations, mostly Queensland, to get some sun. And I found it really, really easy, to be honest. Baxter at the time, that was who the supplier was, and they were absolutely amazing. Really, really helpful with troubleshooting, etc. Then when PD no longer was effective for myself, moved on to hemo. Finding hemodialysis availability in terms of chairs was a little bit trickier. However, not impossible. I still go on holiday, but it just takes a little bit more planning. However, in saying that though, with the Big Red Kidney Bus, that's a massive help. And that's not just a shout out because I work for Kidney Health Australia. It is actually amazing and really, really helpful, because often, you know, the dialysis units are chock-a-block, unfortunately, with, you know, regular patients. So, but yeah, certainly would recommend to anyone just to not let it stop you. Obviously speak to your specialist and your doctor, but you know, part of, I guess, being on dialysis is just trying to continue doing what makes you happy and living life as fully as you possibly can, because you know, it's really important to look after, I think, your mental health, because it's often not discussed enough how it can make you feel isolated and affect your mental health.
Yeah,
regardless of what age you are or where you're from, you know.
There's been a few questions that have come through about keeping your emotional well-being while on dialysis, and I plan on coming back to that, but I also would like to hear, Karen, how you found being on dialysis when you were on holiday or needed to travel. Or oh, you're on mute. You're on mute still. Oh, okay. There you go, you're back.
So just circling back to that mental health part, it's also really important for your partner to be able to have a holiday as well with you. And my husband was really proactive about it and really pushed me about, come on, let's get this organised. So on PD, we travelled from Perth down to Esperance, which is quite a drive, with all the boxes. We had a nice big four-wheel drive. So we took all the fluids and everything that's required. But I did it and we had a great time. Loved the holiday, loved being in Esperance. And that went well to a point. It's quite difficult I was on 4-hourly dialysis, so you're full of fluid and I'm only tiny, like Lesley. And, it's a lot. It's a lot of fluid in your belly and it kind of slows you down a little bit and doesn't make you feel so great. But I did it, we got on with it. And then, of course, when I moved on to hemodialysis, then we start looking for hospitals and found that quite challenging. But also the Big Red Kidney Bus. Now, I booked onto the Big Red Kidney Bus twice, got it all confirmed, was really excited, and each time I got sick before each holiday, and I had to cancel both times, which was a real shame, but that's how it was. And I felt really bad because I'd taken a space, and then so soon before it, somebody else could have had that and they missed out as well. But that's just the way it is with kidney disease.
Yeah.
But I was lucky enough to get to Queensland, to Robina Hospital. I managed to get a chair there for a week. And I was able to see my daughter, who was over there at the time. And that was on public health. That didn't cost anything, which was amazing. And I've been down to Busselton, which is 3 hours away from Perth, on the seaside. I've been there numerous times. They know me well. Always outside of school holidays, obviously. But I've been down a lot of times, and it's just great to get away. I'm a keen horse rider, so I'd go and horse ride all the time because I'm not full of fluid now. I just get the needles in. So that was brilliant, just that kept me really happy. And what else have I done? I've been out on, and I had got a Christmas holiday this last Christmas. I was booked into the one of the Gold Coast, Sunshine Coast hospitals. They'd got a spot for me, and I was able to cancel it because I didn't need it anymore, which is fabulous.
Yes.
Yeah.
Okay. Thank you. We're going to move on to some questions for Roxanne and Tanya. Either of you can answer this, I suppose. At what kidney function level is it normal to go onto dialysis?
Look, everything we do is sort of evidence-based and we research things a lot. And I did a trial many, many years ago, which I was fortunate enough to be a part of, looking at starting dialysis earlier as opposed to later. And the end result was when they collated all the information, they worked out starting dialysis earlier when someone's kidney function is between 11 and 14%. There was no benefit, but that was a case-by-case thing as well, because some people do need to start a bit earlier for many reasons. But what they found is that patients who started dialysis between the kidney function, that's the eGFR, of between 6 and 10 is the average, depending on how many symptoms someone has and what other health problems they actually have and they bring to the table. So that's sort of the rough guide, but it's also case by case. So I've got some patients who've started dialysis when their kidney function's been 4 and 5 because they haven't had any symptoms and they've been really, really well. So it's different, but that's the rough guide and that the evidence shows and supports.
Okay, fantastic. Thank you. We've got a question here from someone wishing to learn more about CAPD. I'm afraid I do not know what that stands for. This person is in end-stage renal failure and will be prepared for a Tinkoff catheter access in the short term. Can you speak to that?
Yeah, CAPD stands for Continuous Ambulatory Peritoneal Dialysis. Roxanne explained peritoneal dialysis as there are two different forms. Continuous Ambulatory Peritoneal Dialysis is the manual way of doing dialysis, which involves a bag of dialysis solution and an empty bag.
Fantastic.
This is what I do with my patients. We touch, we feel, we play with the equipment and have a go. So this dialysis solution, we put this solution inside the abdominal space via the Tenkov catheter. Tenkov catheter is a special dialysis catheter that sits inside the abdominal space, and part of the catheter hangs outside of the abdomen so that we can actually connect the dialysis bag to it. So with that particular type of treatment, this treatment is done anywhere between 1 to 4 times a day, depending on what your needs are. And the automated peritoneal dialysis is when you do it at night time, when you sleep, and you're attached to that machine for about 9 hours roughly every night. But that's every night so that your days are free. So when someone has a Tenkov put in, it's keyhole surgery or laparoscopic, or there's a few different techniques. You're usually in hospital overnight where I work, and then you go home and rest. Then you come into the dialysis unit about a week later. We change the dressings, you meet the staff, and then you go home and rest again, and another week goes by, and then you come back in and we train you how to do the dialysis. But again, every unit does things differently. And if you have to have a hernia repaired or something along those lines, that may delay the start of dialysis as well. So yeah, there's lots of resources on the KHA website with regards to peritoneal dialysis in both forms.
Fantastic. That dovetailed very nicely with what Roxanne presented. I'm so glad you had those ready. Those were also extremely large. How many litres is in one of those bags?
That's 2 litres.
Okay.
And the machine at night time, this is 6 litres. But this is about to be changed to a 5 litre bag by the company, unfortunately. So there's going to be a little bit of wastage, but this is usually 6 litres versus 2. But you don't use all the 6 litres to start with. The machine draws 2 litres out, puts it into your body, and then drains it out. The reason why it's 6 litres so that you don't have to keep changing it at night time.
Yep. Okay, I'm now understanding Karen and Leslie's carrying a lot of liquid on them, and as you said, you were both small. That is a lot of liquid, and it's actually quite stark seeing it in person. So thank you for showing that to us. It's very practical. Thank you for answering that question as well. I was just checking. Karen, did you want to say something? Or
I did go on to overnight PD, which I thought would be brilliant because it leaves my day free and doesn't keep me all full of fluid. I just had a lot of problems getting the balance right. The alarms drove us both mad. It was constantly alarming for whatever reason, and it just didn't work for me, which was really disappointing. And it'll happen, you know, and then it's a case of, do you go back to your daily four times a day, or do you get your peritonitis and then have to lose it all? Yeah, it's just a decision that has to be made. It seemed like a good idea to do the PD at the start. I ended up with 2 hernias, and again, that's because I'm so small, and the fluid that has to go into you is a lot for a little person.
Well,
it's all experience.
Yeah. That I think I might go into another question. There has been a lot of questions about and we touched on mental health, but also emotional support. And I'm interested to know, perhaps Karen, we'll start with you and then go to Lesley. If you have, and you do have a partner in your life or a child in your life, just family members, how much of this decision-making process did you bring them into that process? And like, how much did you decide together? And what would you say to someone because we do have some people whose family members are about to start dialysis, what would you say to those family members? So I guess that's a 2-part answer.
Yeah.
What would you say to family members in terms of what support can they provide the person going on dialysis?
I think it's really difficult for the partner because they have no idea what you're going through and how you're feeling. My husband's really great. He's been brilliant throughout the whole thing. He's very understanding. He's just very supportive, and everybody's different. So, I really can't say. For me, I have seen a psychologist, because there are always times when you struggle. I've had a double nephrectomy as well, and I was terrified about that. I thought I was going to die after the operation. You know, I didn't think I'd get through the operation, and that was really tough. So I encourage everybody to really use those resources if you can. You can get 5 sessions through your GP to see a psychologist, and I thoroughly recommend it because it helped me a lot. Just to be able to talk to somebody, to be able to cry to them, and to then get some tools to be able to manage it was really important. What was the other question?
Oh, how much did you, I guess, bring your husband into
Bring them into it
process?
Well, my husband's been with me the whole way through, so he comes to every appointment pretty much, and then we can talk about it. But for me, I was really set on doing PD at the beginning because my mum went through dialysis and hated it through hemodialysis and had a really bad time of it. Now we are going back. She's been dead 15 years now, so it was 20 years ago, and things have changed. Dialysis has got better and techniques have got better, and so when I did switch to hemo, I was really terrified, but it was so much better. It suited me so much better. There's always hiccups along the way, but essentially it made me feel a lot better. I didn't feel bad afterwards, and I was able to get on with my life on the other days and carry on as normal. But yes, certainly include them if they want. Everybody's really different, and a lot of people don't cope with it very well. And here he is, just listening in.
Hi.
The star of the show. Thank you for your support.
Yeah, so include them if they want. It's nice for them to know what's happening and what you're going through, and if they're uncomfortable with it, then
yeah,
let them be. Yeah.
Okay, so then Lesley, I'd love if you can speak to that as well.
Sure.
In addition to I realize your son is only 13, but one of the questions that has come through on the Q&A is asking if there's any support for a child who has a parent who's on dialysis. So that's a bit of another two-pronged question for you.
Yeah. Oh, where do I start? Okay, I'll be as honest as possible, and unfortunately, it's not unfortunately, like it's a different situation from Karen. I decided that myself and my husband decided that he's very squeamish. Didn't want to deal with it. I'm quite stubborn, and I've always done things for myself. So and only being a couple of months married, I didn't want that dynamic to be seen as him being the carer and me. Not that there's anything wrong with that. That's, but personally, it's a very personal decision. Maybe I was being a little bit stubborn, but I just wanted to do it all myself. The other reason being as well, when I started PD, my son was only a few months old. He was a baby, which suited me for a little while. It was a little bit tricky feeding at night, coming on and off the machine, and hence why I ended up getting peritonitis, as Karen will attest. You say to yourself that it will never happen, but when it's in the middle of the night, you're breastfeeding a baby, like it's just kind of inevitable. So it didn't really work out for me. I was encouraged, being younger, to do hemodialysis at home, which I understand the logic. It gave me more freedom. However, for me personally, having a young child at home and keeping in mind that the only place that I could have fistulas was on my right arm, and I'm right-handed. So I had to do all the needling myself with my left hand. So I was constantly blowing veins, stenosis, and that's why I had so many surgeries. It's almost like every 9-10 weeks, I was having the ballooning and bypasses and different things like that. And also as well, having a young 4 or 5-year-old would just happen to come into mum's room at the time when it was like a scene out of Dexter, and was, you know, veins blowing, blood everywhere. And I just thought, the first time that happened, it was after about a year, I said, no, no more. I tried it. I'm glad that I tried it, because for some people it would work really well, depending on your stature and circumstances. However, for myself, taking into consideration my son and his mental health, I decided to move in centre. And I was much happier with that decision, and made a lot of dialysis buddies in there. But on the flip side of that, unfortunately, you do lose a lot of dialysis buddies as well. And that's a difficult part people don't prepare you for, is it, you know, you spend years with people and see them every second day, like your second family. And sometimes more often you see them more than you do your own family. I'm 5 hours every second day, and then you go in, there's an empty seat, and usually around Christmas time. Yeah, so sorry, I've got a bit off track there. Did you know what else you wanted me to answer? So I'll
actually
answer
another.
anything.
No, that you answered it for sure. I think it's wonderful to hear the not what you're saying, but the different dynamics of families
Yeah,
and how they are impacted by dialysis. And like you
yeah,
said, it is an everyday thing, and so you are making friends. But yeah, so it is really interesting to hear that. And actually, another question has come through
sure.
that fits in with this theme. Alison says, as a carer, I feel I need to show strength all the time. Do you feel that is what is needed, or do either of you think that carers can show their emotions without impacting the patient negatively?
Personally, 100%. I would prefer honesty, you know, and because you know, we're that, and again, it's a personal thing. I consider myself a very intuitive person, so I know, you know, if a family member, whether it's my husband or son, are upset or worried about something, like, I don't like there being an elephant in the room. I'd rather they just ask, you know, and share how they're feeling. Again, look, it's my personal opinion, and look, to be honest with you, Jess, it changes over the years, because my son's only ever known his mum to be on dialysis. I started when he was 3 months old. He's now 13, so it's kind of evolved, and I guess in a weird way, it's probably made him stronger. But at the same time, for me, two things that improved my quality of life was no longer having the fistulas and having them all closed, having my permacath put in, so one in, one out, and you can see it there. Doesn't look pretty, but it saves the pain. It's just, I wish I'd got it done years ago and not went through all of the surgeries. And honestly, as well, for me, again, it's personal choice, not having the machine in my home. It was, for me, it was life-changing in a positive way, because I felt that it's almost like now when I go to dialysis, it's part of my job. I'll go get it done. I'm staying alive, you know, staying alive, and I can come home to my sanctuary with my family without having medical equipment everywhere. And
Yeah.
that's just another aspect of it, you know, and another way of looking at it, I guess. And hopefully that will be helpful to some people that are
Having different spaces.
because yeah, look, PD for me, like Karen touched on, it does have its ups and downs. The downs, obviously, if you're small, the fluid, you do most of the time, I'll be honest, feel quite bloated and uncomfortable. Your blood pressure is usually on the higher side because of the amount of fluid in your body. And again, Karen touched on troubleshooting. You don't really get the best sleep, and neither does your partner, with the alarm going off. But then again, look, there's other people that will sleep through it and sleep like a baby, and you know, it's one thing that I'd just really like to emphasize for everyone. It's not one size fits all. Please do your research, and go with your instinct as well. If something isn't working for you, it doesn't feel right, don't drag it out. There are other options and there are other ways of doing it. And definitely get a second opinion.
Yeah.
You know?
Yeah, that is definitely something that I'm hearing as a repeated message throughout tonight, is it's not one size fits all, and you need to be comfortable with your decision.
Yeah.
I'm mindful of the time. I cannot believe how quickly it has gone. I could listen to you all speak for a lot longer. So I want to fit in just a couple more questions. I'm just double checking that I haven't missed any that we really wanted to answer. I guess this one might be a great one to probably end with, that everyone can answer. But particularly Roxanne and Tanya, as you have been in the business for many years, where do you see the future of dialysis, say, in 5 years? And also knowing that Kidney Health Australia has also put that they want to end dialysis by 2050. So can you speak to that? And yeah, how rapidly is this space changing?
You go, Roxanne. You go first.
I'll go first. I'll let Tanya tell. Yeah. So, look, Kidney Health Australia have got the biggest aspiration that I've ever seen to end dialysis by 2050, which is pretty amazing. And we're going to work towards that happening. I think a lot of the idea around the campaign is to bring attention to kidney failure, and for people to sit back and say, wow, how are you going to do that? And so then people are talking about kidney failure, because it isn't something that is talked about all the time. And there's been some changes in the way we manage kidney failure over the last few years. There's medications now that can delay progression, so that if you get on medications early enough, then you can potentially have an extra 15 years of not being on dialysis if you get picked up early. PKD has its own challenges, but it's still, still there are more medications now to treat it. So part of our aspiration is to focus on a few things. So the first thing we're going to focus on is early detection. So getting those GPs out there to check your kidneys. So people, going out and saying, hey, doc, can you check my kidneys? Because it's not something you don't have, as you might know, anyone that is on dialysis or has had kidney failure, sometimes you don't have a lot of symptoms until you are in kidney failure. So it's a symptomless, quiet disease that just crawls along in the background. A lot of people don't know they've got it until they need dialysis treatment. So yeah, that's what we want to focus on. So early detection, we want to make dialysis better. Like, is there something else we can do other than dialysis? Is there, we know that transplant is a really good option, and Karen has told you already how much different her life is. So can we get more transplants? Can we get more preemptive transplants? Can we get more living donation? So, are there ways that we can increase that as a treatment option? And then in the middle, can we have an artificial kidney that gets implanted? And, there's always stuff in the US at the moment. They're transplanting pig kidneys into humans. And there's actually 2 clinical trials, first time ever, doing xenotransplant, which is pig kidneys into humans. And there's one lady over there, and she's been alive for 4 months post transplant, which is the longest anyone's ever lived so far with a pig kidney in situ. So
I'll be posting that to our PKD Australia Facebook very soon. I'm going to read the article. It's very interesting.
Very interesting. So, so there are things happening in the dialysis space. Dialysis itself, there's always improvements in the machines and the fluids and the filters and all those sort of things, but it still is not the best thing. As you've heard, it's not, it keeps you alive and it makes you can still live your normal life around it, but it's not, it'd be nice if we didn't have to, if we could cure kidney disease and we didn't have to, because we got cure cancer, cure MND, cure all these other things. So let's start working towards finding a cure for kidney failure. That would be great.
Absolutely.
Yeah, I'll hand over to Tanya now. She's probably got
anything
some
to add?
insights.
Yeah, I suppose for me, as far as dialysis goes, it's many years ago. I've been working with kidney patients for over 35 years, and it's evolved so much. But back in those days, it was all about osmosis and diffusion, and no one knew what the hell that was. It's about having a life. It's about, how do I pay bills? How do I have a family? How do I be intimate? The normality of what we take for granted, I suppose. So what we've sort of done is we introduced with peritoneal dialysis is incremental peritoneal dialysis. That's something that was old, but we've reintroduced it. We've trialled it. It's instead of doing 4 bags a day or doing it at night time, you might, if you're still passing a lot of urine, some of our patients do 1 PD bag a day or 2 PD bags a day. That reduces the cost, and it also improves patients' quality of life. They can continue working. They can travel. Our patients travel for anywhere between 4 to 6 weeks and have their supplies delivered nationally and internationally for peritoneal dialysis. So it's about adapting our treatments to fit into our patients' lives as opposed to patients trying to fit into dialysis. So doing it at home, I suppose, makes a big difference because you have that flexibility as well, which makes a big difference. So, and also some of our hemodialysis patients who still have good urine output, patients with polycystic kidney disease, they pee for ages. So they need dialysis to get rid of some of the waste, not necessarily the fluid. So some of our patients might only need 2 dialysis sessions, hemodialysis sessions a week. So it's about tailoring the treatment and it for our patients, and it makes a big difference because we have a lot of patients who do treatments at home. We've got about 350 patients plus who do peritoneal dialysis in all variants, and nearly 100 patients who do home hemodialysis to fit in with their lives and their schedules, and they travel overseas. So it's about adapting what we do and also keeping up with the technology and how to improve things, and also detection, prevention, going to those GPs, and also targeting some of our community groups. We have a big Pacific Island population out here. We're very multicultural in Western Sydney. So we've started a clinic to engage through their churches because we have a lot of patients who are on dialysis. And we've also created a video which is on patient stories. It's Avia's story on the Kidney Health Australia website. He's one of our patients talking about his journey on peritoneal dialysis and to hemodialysis and how he didn't look after himself. And it's just sending a message, and it's done in his language, in Samoan. We're doing a Tongan one as well. So it's getting out to the community. Kidney disease is not sexy. Okay, come on. You know, but we've got to get out there and make it important, and prevention and detection and supporting our patients making informed decisions and shared decision making as well. Yeah.
Fantastic. I'm really hoping there's a shift in the kidney space globally. I'm sure you've all seen the International Society of Nephrology, and actually Guatemala put forward a proposal to go to the World Health Assembly and the World Health Organization to prioritize kidney care. So there's definitely a shift happening. And pair that with Kidney Health Australia's ending dialysis by 2050. That's a message we can jump on board with. We're going to make kidneys sexy again, if only to have people be more aware of them and get them checked. With that, I'm so sad that we have to end this webinar. We're already over time. I apologize for that. If there are any burning questions that we did not get to tonight, because I know there were a few, please email me, manager@pkdaustralia.org, and I can tee you up with someone who can hopefully answer that. Some of our lovely panelists. But as Roxanne started with, please chat to your GPs, your nephrologists, your health team. This is a decision that you will need to make, and ask all those questions with them. And if there's any other questions that are also to do with like transplant or other issues around managing PKD, we do have a YouTube channel, and that is a great resource for any other questions that you may have. We have done previous webinars on those topics. So thank you to our panelists, from me and from the board of PKD Australia. Thank you for taking time out of your evenings, and also for sharing some very personal stories as well. I have thoroughly enjoyed this evening, and thank you, and have a wonderful night.
Thank you. Bye.
Bye.